a nurse in the holistic care team, and I'm a mental health nurse by background. And my role has changed over the last couple of years. And so I was the lead dementia nurse, and now my role is looking at the way that we use or respond to violence and aggression, and how we use conflict management, so the use of restraint in the trust. Last year, there was a new standard that came into place called the violence prevention standard, and the trust is looking at how we kind of respond to this, because we've always had something called zero tolerance in the NHS, but I'm sure particularly with you all working in ED, you'll know that we don't have a zero tolerance. Violence and aggression happens all the time. In 2018, we also had another law come in place called the Use of Force Act, and it's in mental health units, and it comes into power. So all trusts have got to have this in place by April 2022. So it's around mental health units, but if you actually read the small print, it's any CQC registered hospital. So it does include our hospital, and it looks at the way that we record when there's been use of force, so when we've had to force a patient to do something. So what I wanted to talk to you about today is a little bit around what is restraint, what do we do before we get before we start restraining patients, and a little bit as well around rapid trank. So I just wanted to start off, if any of you are willing to answer this, what kind of restraint do you use in ED? Do you think you use restraint?
Yeah,
Well,
chemical.
we
Pardon?
do, yeah.
Chemical restraint.
Yeah, chemical restraint.
Yeah, I think, Beth, we use restraint almost on daily basis.
Yeah.
Not just a few times on day-to-day basis. So restraint is, I know it's a physical and chemical, but the restraint is also, it's not just a holding people down. Sometimes, you have to have a security presence or the police presence just for the people, and the restraint comes in various shapes and form, really, so
Yeah.
it's generally is the containing of the liberty of the people. I mean, if somebody won't let me go to toilet, so I'm under restraint,
Yeah,
we use
and
daily.
yeah,
Absolutely.
liberty comes into it, doesn't it? Because like you said, it's not all around the physical restraint. It's when we're restricting a person's movements, whether they're resisting or not. So we actually, if you use this definition of whether they're resisting or not, we're probably restraining a lot more patients than we realise. Because if they were to try and get up and move, we wouldn't let them. So there's this thing in around mental capacity called like the gilded cage, and it's about how even if you set things up to really lovely and kind of suitable for the patient, if you still wouldn't let them leave, you are still restraining that patient. And this isn't new. We've used restraint for particularly physical restraints for many years. Confused patients were traditionally kept in bedlams, and we use a lot more mechanical restraints to kind of give imaginative ways of calming people down. And this concept of restraining patients in their own good is still what we do now. We do things in a person's best interests. We try to keep them safe, to stop them from coming to harm, and from them to stop hurting other people. So as I said, traditionally in the past we'll have had more mechanical restraints, but we still have a lot of restraint that we use now. So you've mentioned chemical restraints, which we do use quite often in our trust, but also environmental restraints. So things about locked doors or placing patients away from doors so that they can't see them and they're not tempted to kind of stand up, particularly if they've got dementia or delirium. And then we've got a lot of physical and situational. So one thing that we use a lot in ED is things like security. So calling security is a form of restraint. Having a healthcare sat with a patient is a form of restraint. Holding people down, putting mittens or bridles on. And then also things like moving a walking frame or a stick out of reach is a psychological restraint. Telling patients that they can't leave is a form of restraint. It's psychological restraint. bed rails as well. So there's been deaths related to bed rails over the years. And, you know, when we have the bed rails up, it adds to a person's confusion. It adds to their like lack of understanding of what's happening because it's not something that's familiar to them. And it doesn't stop people getting out of bed either. They're going to try and get down to the end of the bed and go around the bed rails. And then positional and mechanical. So tipping the bed back so that the head is lower than the legs to stop them being able to sit up as easier. So that doing that, there are medical times that you might want to do that, but as a form of restraint, it actually contravenes Article 3 of the Human Rights Act, which is to be free from torture. When we use restraints, it's always for patients that lack capacity. So there's legal frameworks that we use, and the majority of patients in ED that we are wanting to restrain don't understand what they are doing. So we're doing it in their best interests, and we do it to prevent harm to them. So under the Mental Capacity Act, we can restrain people under Section 6 because they lack capacity, and it's only to stop them from harming themselves. If someone is about to hurt someone else, then we are protected under common law. There are times as well that when people have capacity, we would restrain them because of the risk of harm to them, to other people. If they've got capacity, then I would want security and the police to be leading on that restraint, and medical staff, nurses to step back from that restraint. If they've not got capacity, then it would be more appropriate for medical team to be leading on that restraint, because obviously the reason that they're confused is most likely a medical reason. And all of you will know how to assess capacity, won't you? So I won't ask you to kind of go through that, but it does often get missed in EDs. There's kind of like I think there's sometimes a misunderstanding of where the Mental Health Act starts and where the Mental Capacity Act ends, and a kind of a blurring of the lines there. And sometimes we'll have patients that are seen by liaison assessed as not being sectionable, but then we don't then think, well, is there anything else to keep them in this place? And that's where we need to be thinking about, do they have capacity? Is there something physical that's impacting on their ability to make a decision? So there's lots of disadvantages of restraint. Can anyone tell me some disadvantages of using restraint?
I mean, we have incidents in our departments.
Yeah.
I still remember it was, I think 16 years old or something, young guy. I still remember the cubicle, that cubicle used to be 10. I think it's still 10 in the corner. I don't know, Bethany, you know or not. So he came overnight with taking all the stimulant drugs, cocaine and stuff like that. And he was pinned down by 6-7 people, whatever. And then, I mean, he died, quite frankly. Okay, I think restraint can be fatal, you know, because these people mostly they have drug abuse, they've got mental health issues, they don't know where are they might have not have food or water for, I don't know how many hours. Then they come to A&E and with the police and, you know, 4 or 5 security and 4 or 5 police and 3 2 healthcare systems. They're all, you know, two each are leading on their limbs and a couple of guys on the chest. So it's a recipe for disastrous physical restraint. I think that's the massive disadvantage. Another thing is that struggle and everything lead to muscle breakdown, rhabdomyolysis trauma. We all know about these sort of hypoxia and, you know, and even we don't know what the blood sugar level is because they're so worked up, you know, they don't let anybody go near to them, and they might be hypoglycemic, you know. So I think the disadvantages are huge, and the mental torture, mental set of stuff. Again, I mean, restraining liberty. I mean, you can guess how much disadvantage is it that guy whose liberty has been restrained. You know, so there are a lot of massive disadvantages. So I don't know. People might be a bit more coherent on that issue, but there are a lot of disadvantages.
Yeah, there is. And I think one of the things you mentioned there was around death. So a few years ago, I think it's about maybe 3 or 4 years ago, there was a death at Wythenshawe Hospital, a guy in his 50s who was he had delirium. And he was described generally as a very calm, mild man. But whilst he had delirium, he was really quite agitated and violent, and he was restrained by security for a number of hours, and died shortly afterwards. And it was seen that the use of restraint had contributed to his death. During that time, there was no observations taken on him. So during the restraint or after the restraint, so it's very much what you've said. We don't know often why the patient's acting this way, and just restraining them is only responding to it. We're not figuring out why the person's acting this way. So whilst we are restraining, someone needs to be kind of responsible for taking their physical observations and making sure that they are physically well whilst this is happening. So risk of death. With patients with dementia and delirium, there's a lot more kind of issues around using restraint. There is a lot more distress, but often in dementia, where people act and how they behave is a way of communicating. So if they're particularly agitated and violent, that's them trying to say that there is something wrong when they can't physically say it verbally. So just responding to the behaviour, so maybe giving chemical restraints to remove their agitation, doesn't let us find out why they're acting that way. It doesn't let them communicate their unmet need. So why do we use restraint then?
To stop patients from harming themselves.
Yep. So it stops people harming themselves. Why else?
To facilitate the actual medical act itself.
Excellent. Yeah. So it facilitates care, doesn't it? So it helps us intervene and find out what's going on. It might keep patients safe and other patients, and it does give some reassurance to staff and people watching that we're kind of on top of the situation. In terms of the Mental Capacity Act, the restraint that we're using must be there to prevent harm to that person. It needs to be proportionate, and it needs to always be the least restrictive. So it's difficult, isn't it? Particularly in ED, it is difficult to gauge what is proportionate and what is least restrictive, because you're dealing with someone that's just presented in front of you and you don't know what's wrong with them. So sometimes we do have to use more force to get on top of the situation and find out what's wrong and how to help that person. And that's absolutely fine to do if we feel that in that moment it's proportionate to do. What we're not as great as in acute trusts is documenting the use of force. What we also need to be aware of is that the benefit of the restraint must outweigh the risks of doing it, and it must be accepted. So I said before that tipping a patient's bed back, it contravenes Article 3 of the Human Rights Act. So that is not a good practice to do. But there is lots of evidence that chemical restraint, it does have a risk, but it improves outcomes for people, particularly in delirium. And it should always be used as a last resort once all other approaches to manage a situation have been tried and failed. So I mentioned before the Use of Force Act. So it's coming into power next month, and initially it was felt that it was just on the mental health units, but the kind of the code of practice and the statutory information was put out in December, and it was found that actually it's any CQC registered hospital. So the things that we need to be focusing on is much better reporting of use of force, and it's looking at what else have you tried de-escalating the situation leading up to it. Why are we restraining? What types of restraint were used, and where exactly the person was touched on their body? who was involved, and specific timings as well. So how long was the patient held? We need to be recording the patient demographics, particularly things like if they've got mental health conditions, did they have lack capacity at the time, any injuries for both the patient and for staff, and what legal frameworks were we using. So it's more often than not, the kind of our legal framework in acute hospitals is the Mental Capacity Act. So that's the main one that we're using for restraint and use of force. So we have a policy for rapid trank for over 65s lacking capacity in this trust. And it's very little, and there's a lot of information on there. So I'm not going to go through everything, but I just wanted to show you that it's 3 steps. So we start off with the non-pharmacological interventions, moving on to step 2, which is oral, and then step 3, which is intramuscular. It is a guideline. It's not a fixed like tram line. You don't have to go through each step, particularly in ED. There's going to be loads of times where you have patients where it's necessary to go straight to step 3 to get on top of the situation, to keep the patient and other people from harm. What we need to be wary of is when we give any kind of medication that it does have an impact on the body beyond controlling their behaviour. So in the guidance and nationally, what we have to do is monitor the patient's observations every 15 minutes for the first hour, and then 30 minutes for the second hour. And use of rapid trank is restraint. So if we're using it to get on top of a patient's behaviour, then it's a form of restraint, and it has to be documented. There needs to be a datex so that the trust has got that record there that we've used that level of force, that the situation has got to a point where the behaviour is so unmanageable that we've had to use rapid trank to get on top of the situation. So there's lots of things that can impact on a person's behaviour that we need to be aware of in the non-pharma kind of step. And just being in a different environment, so just being in ED with all of the people around them is going to massively impact on how that person behaves. So obviously they presented at ED, there's something going on with the health and brain function, and the other people as well is going to impact on how they behave.
Okay, for you guys,
Come
you
on
have
there.
to enjoy. Once you finish your shift, go and enjoy, right? You can't enjoy later. One day you will.
Someone want to turn
come to my
their
situation.
button on mute? I can hear a conversation. Oh, lovely. So I've got some ideas here. That
You finish your work, completely forget about everything.
do we know whose conversation we can hear there? Oh, lovely. Thank you.
I've muted already. I muted
Thank
that
you.
person already. Thanks.
Cheers. So there's just some ideas here of what you can do to kind of get on top of the person's behaviour before they come in. Having someone that knows them is really useful. So, and obviously the visiting is been restricted recently, but anyone with dementia, suspected delirium, mental health problems, learning disabilities, anyone that has increased daily support needs at home, it will be a massive benefit if they're allowed to have their family or friends or carer in the department with them. And it is a cause of a lot of complaints as well, that staff have said that they can't come in, particularly when they've had dementia, and we know that having them there would be a massive benefit. I've put in here a little bit about validation as well, which I'll come on to in a bit more detail, but paying attention to what someone's presenting like emotionally. So not just listening to the content of the speech, because sometimes that doesn't always make sense, but seeing how they're feeling and paying attention and validating their emotions is a really important tool in kind of calming a person down. So we'll all be aware of these kind of things, and we'll all have experienced these things ourselves as well. And a lot of our patients in ED will be kind of experiencing these things as well. And this is another thing why it's really important to have a family member there, because they can tell when the person's behaviour is escalating, and they will have more of an idea of what to do to calm them down. So thinking about your part then, as well as picking up a lot of information from that person's body language, they're also going to pick up a lot from our body language as well. So keeping your body nice and calm and relaxed and open, not pointing your fingers, not having your hands in fists, facing the person when you're speaking to them, and focusing on the facts or feelings I've put here. So if someone says to you, I want my mum here, and they're like a 90-year-old with dementia, and you might know that their mum's not there, saying to them, your mum's died or your mum's not here isn't going to help the situation. But saying, I'm really, I can see you're really upset. Maybe I've not got the number for your mum, but I've got the number for your daughter Jane. Shall we give Jane a call and try and focus on the feelings there? And acknowledge the emotion as well. So saying things like, you look really upset. I can see that you're angry. And I've put at the bottom here about avoiding invalidation. And this is something that we talk to security around as well. Because in reviewing like their body cam footage, we can see this comes up a lot. When someone's getting angry, they say calm down, and they try and get the person to calm down by saying, just calm down, it's fine, calm down. And in the history of the world, saying calm down to someone has never calmed someone down. So it's thinking about the way that we respond to someone. If you're in imminent danger, which I know in ED there is often a lot of times where you are physically attacked, it's calling for space and thinking about the area that you're in, and clearing help, clearing the space as well. So what we suggest on the wards is treating it a bit like a fire evacuation. So if there was a fire, you wouldn't pick up the fire and run out with it. You try and get other people away from them. So if you can move other patients away from them, I would do that and give that person a bit of time and space to de-escalate by themselves. And that will also give us a bit more time to ring security for help as well. Now, have any of you been on the conflict management training, the physical interventions? I'll take
Yes,
this
I
time.
think
No.
most of us should be, but I've been definitely there on conflict resolution.
The one here, so not conflict resolution, it's the physical interventions one. So how to hold people safely, how to disengage from if someone's got their hands around your neck. Have you done that training?
But I have.
You have, yeah, the one here.
Yes.
Yeah,
Lovely. So we've had this training up and running from October, and it's open to all ED staff. Now the trust the funding for it has recently run out, so in a couple of months' time we will be restarting it again when we've got more funding. But what I've asked for specifically is ED days, so some days that are just for ED staff, doctors, healthcare nurses, because you really work very closely as a team. And I think it's important that you learn this information and you learn the kind of the holds together. So in a few months' time, you will be doing it will be open to you again more on how to disengage from situations and how to safely hold someone while someone's being physically aggressive. I won't go through these because I'm sure you're all very aware of them, but I just wanted to point out that this is for over 65s. For those under 65, you would be following national guidance. The reason that the trust has currently only got over 65s is I wrote it, and I'm a mental health nurse and I've worked in old age. So I said I was comfortable doing the old age one based on the information we've got. There will be an adult one being made and a children's one as well. But for older people, it's 0.5 we would be starting off with lorazepam, and it's a maximum of 2 milligrams in 24 hours. There are always going to be times that we go above that amount, but we just need to justify why we felt that was the case. And again, this is only for when we're controlling a person's behaviour. It's only when we need to do it to rapidly kind of get on top of a situation. If you've got someone that's detoxing, if you've got someone with epilepsy, there is loads of other times that we would use lorazepam, and it's not kind of, we're not restricted by that amount. You know, people who are detoxing would have like much more than that, but this is around rapid tranq to get on top of someone's behavior, and then obviously leading to IM. after an aggressive incident, we need to datex. We need to record what's happened. I get all of the datexes for any kind of physical interventions, any violence and aggression. What we found is through, so that's the last year, in 2021, how many datexes for violence and aggression do you think there were in Doncaster ED?
Probably none.
There's a few more than none.
Okay.
I'd say at least 20, considering how bad the year was.
20.
Yeah.
Yeah. So how many times do you think you get physically attacked or any kind of violence and aggression in ED at DRI?
Probably every day.
Not more than 20.
Every day? Yeah.
Yeah, so every day some sort of instance is there.
Yeah. So we should have a lot more than 20, shouldn't we?
Absolutely, yeah.
Yeah. So that we have, it is actually 20 that you've had last year that have been recorded on Datex. But we've been doing an audit for the last 3 months. But I don't know if for those of you that are Doncaster based, you've had a like a blueprint of ED stuck at the horseshoe with some blue and some red stickers, and we've been looking at the last 3 months for staff to put a sticker exactly where the violent and aggression happens in the department. So it's a red sticker for physical and a blue sticker for verbal, and we've been asking people to stick that on. And over in January, I think there was around 42 stickers put on, and there was only 2 datexes. So it's happening, and that's physical as well. So we're not recording when it happens, which makes things difficult for the trust to see that there's a need for more intervention. So recording things is really important for that, and it helps with kind of planning for that patient's care in the future as well. But what we need to also be thinking, as well as completing a datex about why we restrained, what happened and everything, it's thinking about what was that person, why was the person acting that way, what does the person need, what were they feeling, exactly what happened. If we don't understand why the patient was acting that way, what they were feeling, then it's likely to keep happening. So just some food for thought at the end then. It's just thinking that we use restraint all the time, and if we're caring for a restrained patient, then when we're responsible for that decision. Is the restraint proportionate and legal? What else have we tried before restraining that patient, and are we using it for the right reasons? And if someone walked into your department, had a look on Symphony or picked up the notes, would they understand why that level of restraint was being used and if it was justified and proportionate to the situation? Let me get back onto this. Okay. I can't make it bigger now. Has anyone got any questions?
I think it's because in the senior doctor level, now even at the junior doctors, because we identify a lead on something, for instance, a stroke lead. I think recently we have a Stacy, I think she is a senior healthcare assistant. She is lead on disability and learning, that sort of problem. I think I think we don't have any lead on substance misuse and restraint, these sort of stuff in a nursing side. These things do help if we have somebody who's got a bit of designated role. And I think because the trust, of course, all the manager and people, they don't want to pay. I think, making a little bit job plan about that particular person does help, because there has to be some incentive, because these things, they don't happen automatically. They have to be, they take time and they take effort. I don't know whether, yourself, and because now it seems to be a big thing for the trust, because the CQC, some some role can be created in the nursing sort of thing, where 1 or 2 people come together. They might be paid, 1 PA or 0.5 PA, whatever, and they should look after this sort of situation. And we have seen time and again that these sort of measures, they do work, rather than when you say, oh, it's everybody's job, so nobody does the job then. I think they do work if we could think of these sort of issues.
Yeah.
And
I
we
think
know that.
there does definitely need to be a lead, and as part of the standard that's come in, there will be kind of a committee to have to link all of these things in, and we're wanting to have starting off in like the kind of the nursing and the healthcare roles is around having champions in each department that will kind of take the lead on responding to violence and aggression, and push the need for reporting and the need for training as well. So to have a role in from a medic point of view as well would be really useful, so that they can kind of link in and work together. A lot needs to be done, particularly in ED, where you do see the most violence and aggression. Like the research has shown that someone is going to be violent and aggressive, it's going to happen within the first 100 minutes of their time in hospital, and that is in ED. So you do see it significantly more than any other department.
Yeah, you're right. Because these sort of roles can develop pathways, policies, and stuff like that. Yeah. Yeah, Martha. Yeah.
Yes. Good morning, Beth. Thank you very much for your teaching. I concern about, because there are 2 kind of patients for me, no, or 3, no. If you see, there are dementia or the elderly that they come with dementia, sometimes very with delirium. That is true, because sometimes because the illness, and sometimes you have patients with drugs, no, they come with alcohol, and then also the children when they are really stressed and it's not possible to do a few things in children less than in the adults. But in the adults, for example, we have the problem at night shifts, that is sometimes you have 3 or 4 patients at the same time with the same situation, that they want to jump out of bed, and then they are reluctant to use for me the chemical is better than other kind of, because the beds, even when they put up like this leg up, they jump if they really agitate from the bed, and it's risky than give some lorazepam. No, I always go for lorazepam if even sometimes giving 1 milligram you cannot reduce, because they are very strong. Then, as Mr. Jan say, we need some help sometimes, because we, as a doctor, we cannot spend with so many patients at night, and few doctors just trying to keep the patient in bed. It's very difficult situation sometimes, no? And sometimes the nurses are reluctant to give, or even the consultant to give some chemical to get them quiet. Even the alloperidol for me is less to use, but the lorazepam could be used, as you say, 2 milligrams maximum, but sometimes even once was necessary to give 2 milligrams of diazepam, because lorazepam was impossible to keep quiet the patient, one of them.
Yeah, and I think there's kind of sometimes there's a reluctance, isn't there, to kind of increase the amount that they're on, and sometimes we need to give it to get on top of the situation. So I think there's a lot that needs to change in the trust as well around support networks on when someone's at risk of getting out of bed like that. We used to have something called the enhanced care team, which was disbanded a couple of years ago, but it's something that we're considering bringing back in the next year. And that's a group of trained health cares that are there to support patients when they are becoming more distressed and agitated. So they will be able to come and support different departments, come for a few hours and sit with the patient and help kind of try and de-escalate the situation. And I think it's often, particularly in ED, when they are left alone and you've got so many other patients to look after, it's a de-escalation that doesn't happen because you don't have time to do it. So you only respond to the end presentation. You don't have time to do the de-escalation bit. So having someone there, having someone physically sat with the patient would help and reduce the need of getting to like the use of lorazepam, because they're there to de-escalate them beforehand.
I think now I've seen electronic de-escalation, you know, this light and fish and stuff like that. I think in dementia, they really like it.
Yeah.
But unfortunately, we have got only one machine. I think we need a few more machines. They really like it.
That's ours. We've lent it to you.
Oh God, yes.
Yeah.
So lend us a few more. That's a very good, really. It's amazing how they
do
respond
need
to
more.
that.
You know, I was in ED probably about a month ago, and you had a patient in his 30s that had a learning disability,
Mhm.
and I went and got the TV over in the paediatric department, and I
Yeah,
brought the TV over for him so that he had something to do, because obviously the sensory trolley wasn't appropriate for him. He would have got really annoyed with that.
Mhm.
But just watching a film on TV, that helps settle him. But you need a lot more stimulation in ED than you have, because people stay there for a long time, and it's not really the appropriate place for them. But if we
No.
get some more sensory trolleys, I'll let you know.
I think that would be great, because it free the stuffing. The problem is, because if there are a couple of people, as Martha is saying, then the problem with the stuffing comes up, because the healthcare assistants are tied up with the patients, and then we don't have staff to do other stuff. So it's a really catch-22 in A&E. I think these sort of simulative methods, they really work.
Yeah, you do need more physical kind of stuff in there to calm and distract. And then if we do get this team, the enhanced care team, then it's someone that, even if, because they're not going to, for the whole trust, they're not going to be in every department every day.
No.
But if you've got someone for 4 hours during a particularly busy time that is there to support with your more challenging patients, it's of benefit to them and to you as well.
Of course it is.
One thing more, the didactics, if you, every time when you have this kind of incident, you suppose who is going to do the didactics, the doctor, or, because I never see, I don't know if the nurses, they did that when we have many, during the night, I tell you, it's really impossible, because even nurses are not there. People, when they fit in races and they start to get very confused, they get really strong. And then even the doctor, when the doctor leave the patient for a few minutes or maybe 10 minutes, then he start to take the cannula out. That is really big concern for me. I don't know, but it's very difficult.
Yeah, and I think we're not going to solve everything, because
No.
people will always become confused and agitated. So we're not going to solve everything, but there are things that, plans that we do have that will help with the situation. With regards to who does the day text, whoever's involved in that situation can complete the day text, and I think it's a discussion at that time. We need to be better at it. We need to be better at, like, saying to someone, right, who's going to do the day text, who's going to report this, because I don't know it happened. If the day text isn't filled in, I don't know it's happened, and I don't know to come and support the team.
I think for the day tax, for my colleague, I will advise that just mentioning to the nurse, staff nurse, nurse in charge, can you please fill up the day tax in this situation? I think they're very good in doing that. I think regarding chemical restraint, I don't know what clinicians think about that, because I would prefer the medicine where there's an antidote, like benzodiazepine, haloperidol. There are merits and disadvantages of haloperidol, but generally, the senior people will be recommending using medication where we have the antidote against. Because if somebody gets excessively sedated, then you can give a bit of flumazenil, and it works in seconds. And then you can adopt other measures.
That's true. The antidote, yes, I prefer also.
I think the other thing is calling anesthetist, because if sometimes the people are so strong, they're so muscular that you can't envisage that a 4 milligram something lorazepam would work. In that situation, I think asking the anesthetic colleague to come in So the anesthetic should be coming in because that's one of their job. Because invariably in them people, there's something else going on. And if we can miss there's something else going on, then it can be quite devastating. So I won't hesitate to ring even fast bleed the anesthetist to pop in. And you can put a venflon in a cannula, and then anesthetic and sedate, or they can even intubate and do scan and stuff like that. And the blood test. And
Mr. Jan, thinking about the dose and also the dose when they take in care home or at home some lorazepam, they create tolerance to benzodiazepine. Then 2 milligrams is not enough. Then you must know which medication the patient have at home or in the care home to act. Then that is very relative when the patient has more medication, about just to control them in care home or something that you must know. If it's new, the patient is new, just never take lorazepam or no in the medication. And then I think we'll work with little dose, but no in patient when they have so many medication just for psychosis, for all these kind of things. No.
Can I just suggest, please, Bethany? There was an email as to these facts that was sent around, and I did ask Ruth, some of the secretaries, if we could get laminated copies in ED. We have a file holder in ED. So at times in the middle of the night, the junior doctors, SHOs may struggle to find the guidelines, the steps to use. So if we have it, laminated copy right there on the file holder in ED, so that people can have easy access to guidance on what to do.
Yeah, is that, what email was that? Sorry.
Oh, I don't know if you're copied into that email, but I sent it to the I sent it to the secretary.
No,
Okay.
Bethany,
So
Bethany,
when this first came out.
Yeah, all Bethany have presented the facts is that's why and what steps. So these the same steps I think on the email. I read the email. So just
Okay.
eliminating that steps.
Exactly.
Yeah.
Okay. All right then. Yeah, I can get some copies and bring them over. I've also got some information on like types of restraint and de-escalation as well, and I'm happy to bring them over as well, just so you can kind of keep it all together.
Yeah, that's very big.
Because juniors might not know what to do. I mean, it's good we've had this teaching today, but not everybody is present here, especially the new ones. So if they have a patient kicking off, and first and they've tried de-escalating, talking the patients down, not all the juniors know what is within their realm of use. But if they have this as a laminated copy present in ED, they can easily consult it for guidance.
Yeah. Are you all DRI, or is there anyone here from Bassett Law?
We mix.
It's a mixed.
Mixed, okay. All right. So both sites, security receive the same conflict management training that the clinical staff do. They take it a bit further and go to a higher level. But it would be really good of kind of everyone working together to get this information and to kind of to restrain people together. If you need support in restraining, obviously the security staff are very good at doing it, and they will be able to help with kind of getting lines in as well. So obviously they're not going to do that, but they've been trained of how to hold someone's arm in a way that you can get cannulas and stuff in as well, just to let you know.
Oh, honestly, our security are very good. In many cases, they are very effective, and they really assist. They know how to hold the hands, to position it for you to put a cannula in.
Yeah.
That is good. But like you said, the escalating techniques it's always good to start with, to talk the patients down, calm them down before we go.
These are real.
That is
The
great.
real
Yeah.
situation is
Yeah.
one of our sister. Now she's a sister now, so she was a staff nurse. So she have a needle puncture when restraining. So actually, actually she she sued the hospital. Anyway, so then she realized that it's her own organization, so she should be. So these are real situations. So there's a financial implication as well. So when somebody's injured and need a break injury, that sort of stuff. So I think it's a very vital subject. But I think to me, it will be some sort of structure setting up in A&E where they can meet together and every so often and, discuss these sort of stuff. And then I think then the process and procedure will keep on working really.
Yeah.
I've got one thing to ask Bethany, because we are dealing with lot of dementia patients nowadays. What I've observed so far is they've got good, the hand flicking movements. They want to touch everything. They are more like a childish behavior. They want to touch what's going on in their arm, like that cannula. That touch sensation is what they really require for them to actually calm down. So I've seen in several of the trusts that they actually give either teddy bear or some kind of a doll with kind of like jingle bells as well on the side. So if you know what I mean, I just don't know the exact terminology used for that particular doll, but that has actually worked a lot. And actually there is something like a pocket that goes.
No, you've just gone on mute. We have what you're referring to, the pocket thing. We have twiddle muffs in the trust that can kind of fit over a person's arm and sit over the cannula. We do have that. We can. I know it was Sheila, the housekeeper at DRI. I was talking to her around fundraising and getting these kind of things in place. But again in ED, we put a twiddle muff. We pulled it over the patient's arm where the cannula was, and it stops them touching it. You can also get a lot of the plastic kind of fidget toys and stuff just from Amazon that just gives them something to hold in their hand and fiddle with and twiddle and stuff, so that they're tempted to kind of pull at different lines.
I see these days some machine with lights, and that works quite well into patients. I see they distract with they put this big machine with so light that they get really relaxed and little bit quiet. No, of course, no, but it's working.
Yeah.
I think I don't know if we just have one or two, but when the nurses try, they get quiet.
Yeah, you just have one. You have one of them, but yeah, they make a massive difference, and it often de-escalates the situation before it gets to the point of needing any kind of physical intervention. So it does help massively. But yeah, any kind of, so I've talked to Sheila about fundraising, and you can put in bids through charitable funds as well, or you can just do a bit of fundraising in the department as well to buy these kind of things. You can just get them off Amazon. Lots of different kind of twiddle and fiddle gadgets and things.
Yeah. Hello.
Hiya.
Yeah. Thanks, Peter, for your presentation. Yeah. I think most of the things that have been said are quite useful. But most importantly, I think A&E is fast becoming a word, to be honest, because patients are spending much more time than they should. So I think as a background, once the flow system improves, we'll probably deal less with this problems, because a lot of times by the time patients spend 12 hours, 18 hours, 24 hours in ED, that's when they get really upset, and there's really nothing we do a lot of times to settle them. So I think by the time we improve the flow system, a lot of these things would probably not be needed in A&E, most likely.
I like your positivity when it does improve. So yes, it will. And I think, yeah, so until then, we need to be more accepting of family members staying with people, because they do get stopped at reception, and it's something that I've spoke to reception staff about as well. And hopefully when we've got this enhanced care team as well, we can support and provide more physical presence of people, and then doing some fundraising of kind of the activities and stuff to keep people occupied whilst they are spending more time in your department. Anyone else got any questions?
Well, regarding the kind of I know the bed availability is always a difficult situation in A&E, as well as like going up to the ward. I have seen there's a lot of debate about like whether to keep the patients, like especially the dementia ones, in the department or kind of move out as soon as possible, because that is what the whole, you know, the sound, noise, those environment they are not familiar with. And I have seen some dementia nurses actually dealing with these kind of issues directly with the psycho and getting the beds as soon as possible for them, because them people, if they are waiting in the A&E for too long, they will use up a lot of manpower in terms of calming them down. And basically you are tending towards something which is not emergency, and it kind of like uses our A&E resources. Have you actually looked into that aspect as well? Is there anything going on from that aspect?
Yeah, so it definitely there's a couple of people in our team. So we've got the dementia practitioner and the delirium practitioners have been looking at flow and where's best for patients. Even things like on AMU as well. There's the kind of the high pass kind of like turnover of patients and the lack of activity and the lights and stuff being on, it is really distressing for patients. So they shouldn't be spending long time in your department or on places like AMU, ATC. They should be a faster. So it is being looked at. And that's again where we need to be thinking as well of having family members there and getting them moved and getting them comfortable and getting them with someone that they know whilst they're waiting to move.
That is good point. One of the patients that was very agitated with delirium was 21 hours in A&E in the same room, very tiny room, very strict. And I say, I cannot believe. I left my shift, and then when I come back, he was already there. Then anyhow.
It's not right at all for someone to be spending that amount of time. It will significantly worsen the situation for them and for everyone else. Any other questions or comments?
So regarding this patient, I was just wondering, regarding these patients who are like delirious, dementia, and had to be admitted, what sort of like a frailty team, do they actually work with us in terms of one, de-escalation, second, early bed availability at their place? Usually they're like fall people and not having any significant situation, otherwise mobility issues, need a rehab bed, things like that. Is there any frailty team acting on to that sort of kind of?
Yeah, I believe that is it Dr. Mahmood who's based on the Gresley unit. He's been looking at kind of the frailty pathway in ED as well and getting people home quicker. That's what my understanding.
Well, he started to review some patients, and of course they are now, I think, more. They say, no, you send this patient home. I say, no, this patient needs review for you, because I think he can, and the patient cannot go home. I think it's not a question to discharge. It's the question when the doctor in A&E decide that this patient cannot go, because the first assessment, I know sometimes it's not, they come to see, but sometimes they are not coming, they finish at 5, it's the consultant. Then we cannot keep this patient there, for example, all the night, because the consultant is not there just to approve to take this patient to frailty. That for me was new, no, the last few days, and I say, oh God, okay, but you cannot, the patient cannot wait for someone to come to see if he's fitting in frailty or not.
So is this basically there's a lack of a system overnight and not in the day?
Yes, I think so. And then I think the senior clinician is good enough to decide if this patient can go or not. For me, that is absolutely, and more for frailty. They can assess in frailty, but they cannot stop the patient in A&E to say that the consultant is coming to see or the nurse to see if he's fit or not for frailty.
Okay.
I think, yeah, Martha, because that's the reason is the medicine is very much a culture thing a religion thing. Medicine is not that sort of engineering sort of stuff. I think because in here, being a nuclear family and then, you know, people working across whatever. So, you know, it's a multifaceted problem. For instance, if we discharge people home, if there's no medical intervention needed because the people need to be away from the hospital to care home. So then the logistic problem, transport booking and all this stuff. So a lot of stuff, you know, need to be done. In Hull Royal, Dr. Anderson is the frailty, you know, lead there. She's quite senior doctor and she is very good. So they have put all this system, this model working there. So much so now they are contemplating to hire the air ambulance, something like a helicopter, something, because they have so much advanced in this system. They've got a special desk in the A&E where every 4 hours people get together from R-, you know, rapid assessment, social services, ED, frailty people, they get together in a board round, they identify patients which need to be discharged and they start working on it. So that model might not work with us, but some sort of model in a similar footing we need in our A&E as well. And more importantly, the disseminating information that such a service is available. So I think he was telling me that they are going live on Monday, Dr. Ash. So hopefully, you know, we will catch up with Hull Royal. That's what we are trying to follow the model of Hull Royal, really.
Yeah, that sounds really exciting. Then hopefully it will make a difference.
Yeah, make some difference, yeah.
If there's no other questions, I'm really happy for you to contact me. Hopefully you'll have my email. If not, Boone, I'm really happy for you to send it on. And I'll get some laminated copies of the pathways and bring them up to ED as well. I'll take them to both EDs.
Okay, thanks, Beth.
Yeah, just to check home, Bethany, just the last thing I need to add a little bit. So with what your presentation today and with what we can do, what are the practical methods that we can actually apply right now as we have got that availability to in A&E regarding the restraint, apart from the chemical ones?
Yeah. So the chemical ones, yeah, there is a pathway, but what I would want you to do is to ensure, basically make sure that we're involving families more, whilst the visiting is restricted again, have a lower threshold to having family members there or having carers, friends there. Think around the de-escalation side of it first and why someone is acting the way they are. Have someone responsible whilst you are physically restraining someone, have someone responsible for taking observations and thinking about why the person's acting that way. Working with security and making sure that you're detecting when there is any kind of use of force of a patient or any kind of aggression from patients.
I think, Suraj, when I think physical restraint should be one of the indication of chemical restraint, quite frankly, because the physical restraint is bad, you know. So it doesn't look good if a patient has been, you know, put in chain and, you know, I mean, in the matter of fact, it's a chain, is it? So holding all the arms and pressing them down and somebody sitting on the chest. No, that scene is ugly, absolutely ugly scene. Yeah.
So Bethany, thank you very much for coming to join us this morning and sharing your expertise with us regarding this restraint. I will share your contact details with the rest of the group in our little chat group, and I'm sure we'll see you in the department when you come round. Thank you very much for your time today.
Thank you very much. See you later.